Hello, everyone. I'm Manu Malbrain, an internist intensivist from Belgium and affiliated also to the Medical University of Lublin in Poland. It's a great pleasure and an honor to be here today and to invite you to join this fantastic webinar organized by the World Kidney Academy on all things renal and cardiac problems in the ICU. Today we have two excellent speakers, and the first lecture will be on cardiorenal syndrome with a clinical case scenario given by Professor Amr El-Husseini. Professor El-Husseini is Professor of Medicine, Medical Director at the University of Kentucky in USA, and is the Vice President of the World Kidney Academy and President of the World Institute of Critical Care and Emergency Medicine. The next lecture will be on ultrafiltration in critically ill patients. We know that volume overload and fluid accumulation can have detrimental impact on end organ function, like increase in extravascular lung water or maybe increase in intra-abdominal pressure. This lecture will be given by Professor Hesham Elsayed, who is Emeritus Professor of Nephrology in Shams University, President-elect of the Egyptian Society of Nephrology, and editor of different hemodialysis guidelines. He's chair of the African Committee for Hemodialysis, as well as academic director of renal replacement therapy and blood purification fellowships. So I'm also happy to introduce my co-chairs, which is Dr. Ricardo Matos, intensivist from Portugal, has been very active between the European Society of Intensive Care Medicine, where his main focus is on education and training, has also been involved in the Portuguese Society of Intensive Care. Next, we also have Marcus Broman, who is intensivist from Sweden, but is now also working in Abu Dhabi, as well as Khaled Swify, who is from Egypt and now based in Saudi Arabia, and they will introduce themselves when we will get to the questions and answers in the discussion session. So without any further delay, let's kick off this fascinating session.
Hello, everyone. We have a short case for discussion today. It's a case of cardiorenal syndrome, and it would be an interactive clinical case-based discussion with Dr. Rania Omer. She is an ICU consultant in Abu Dhabi, and we have Eduardo Terzolo, who is a nephrology resident in Italy. So we have diversity here between Europe and Asia, and also between nephrology and ICU physicians. So our case is a 35-year-old male patient with a history of advanced congestive heart failure with ejection fraction around 35. And he was admitted to the ICU with worsening volume overload and AKI, so typical cardiorenal syndrome. He was sedated, ventilated, he was hypotensive on 0.2 mics per kilogram per minute of norepi. And over the last 48 hours, his urine output was declining, and now he's only producing about 20 cc of dark concentrated urine. He has AKI was rising creatinine up to 6.7 from a baseline of 1.4 milligram per deciliter. Now his BON is 140, and his oxygen saturation is 92% on 50% FiO2. And this is his chest X-ray, the most recent one. And here is our first question, and I think ladies comes first. So let's start with this question, and I will allow Dr. Rania to read the question and to try to answer this quick question.
So, hello, Dr. Amr, Dr. Eduardo. I'm very happy to be with you today. Let us start with the answering of with this question following the case. Which of the following statements regarding dialysis modalities is incorrect? Choice A, studies comparing extracorporeal ultrafiltration with diuretic therapies have conflicting results. If there is a substantial need for solute clearance, chronic kidney replacement therapy would be better than intermittent hemodialysis. PERT, a prolonged intermittent renal replacement therapy, is a hybrid hemodialysis modality that is longer than the conventional hemodialysis and offers diffuse solute clearance and a slow ultrafiltration. When the goal of kidney replacement therapy is solely volume removal, SCUF, slow continuous ultrafiltration, would be the option of choice. And number E, regardless of the modality of kidney replacement therapy in cardiorenal syndrome patients, the mortality rates remain very high. These are the five options that we have for the question.
Which one would you pick? So remember, you are choosing the incorrect one. Which one would be incorrect?
Which one would be incorrect? I would suggest, let me read my mind out loud. I don't know if this is studies, again, comparing extracorporeal conflicting results. I think, to my opinion, is answer A.
Okay, you think that there is really studies that showed,
they don't.
Differences between diuretic and ultrafiltration?
This is the incorrect answer, right? They don't have conflicting results, right? They don't have conflicting, both of them.
You think all studies have consistent results?
Consistent results, meaning that they all show good mortality. This is what is meant, but this is all show good benefits from the ultrafiltration. Right? Just let me take another look. There is a substantial need that we can remove. Just
okay, that should be fine. So thank you again for trying to answer this question. And here is the right answer. So choice B is the incorrect one, because they mentioned that if there is a substantial need, so if there is significant need for solid clearance, in cases like hyperkalemia or severe uremia or severe acidosis, CRRT would be better than intermittent. Of course, this is wrong. It's not unusual, actually, to start, couple hours of intermittent HD before starting CRRT, just to get better clearance, because it's low continuous therapy. From its name, it takes longer time. So if the patient has severe hyperkalemia, EKG changes of hyperkalemia, you don't want to wait for 6 or 8 hours or 12 hours for this electrolyte imbalance to be corrected. So you usually try to start a couple hours of intermittent HD. If the patient can tolerate, then you switch to the CRRT. For the first option, option A, it's actually correct. Several trials evaluated the clinical impacts of extracorporeal UF and compared it with diuretic therapy. And of course, there was conflicting results regarding the benefits and the risk of each modality. Here is some advantage, the upside of using extracorporeal UF. You usually get greater fluid removal, about 1.4 liters, and better weight loss in a shorter time, lower chance of having advanced, worsening, congestive heart failure, acute decompensated heart failure, or chronic congestive heart failure, lower risk for rehospitalization, lower risk of electrolyte disturbances, and of course, there is no gain without pain. So all of these advantages could be limited by either the catheter placement insertion complication or because of the ultrafiltration, rapid fluid shift and removal would be associated with more hemodynamic instability and hypotension, especially these patients are mostly have some kind of cardiogenic shock or at least hypotension. Of course, we have several ways to control the uremic milieu or the volume overload in our patients. We have several intermittent and also slow continuous therapies. And these therapies, we usually choose depending on, of course, the availability in our centers and ICU, and also because of the hemodynamic stability versus instability, the degree of uremia or kidney failure, and the need either for fluid removal or just if we need more clearance, more diffusion. So it depends which one we need. We need to remove fluid. If we need to do this, we can do a scarf, which is a slow continuous ultrafiltration. If we need to do both, we can do CRRT. If there is really an urgency to improve the electrolyte imbalance or the acid-base disorder, we try to do intermittent HD. Of course, peritoneal dialysis is always an option for chronic therapy and also for acute therapy. And again, it's one of the slow continuous therapies. Again, if there's significant need for solid removal, we need to do intermittent HD, which is rapid, the quickest way to improve the electrolyte imbalance. BERT, which is the prolonged intermittent renal replacement therapy, is a hybrid model between the continuous and the intermittent, and it's usually done for more than 6 hours. And we do this repeatedly over several days to remove fluids and also to do better solute clearance and hemodynamically unstable patients that we cannot do intermittent HD. Again, all of these modalities we use depending on our aim for the dialysis. Is it mainly for fluid removal? We do UF, whether intermittently or with the scarf or CRRT, or it's only for correcting the acid-base disorder. So we need more diffusion and convection. The truth is, regardless of the modality of renal replacement therapy, sadly, still the mortality rate in cardiorenal syndrome is very high. It's about 70%. Hopefully, we can see some changes and improvement in this mortalities in the near future. Here are some updated references, 2023, 2024 references. If you need to read more, you can go ahead and read these articles. Okay, Edu, this is your turn now. Do you want to take this question?
Yes, of course. Thank you, Professor. Thank you for the opportunity to be here with you. So we need to find the wrong option in these 5 statements. So option A, the ultrafiltrate usually has less sodium concentration than the equivalent volume of urine. Extracorporeal UF fluid is isoosmolar. Ultrafiltration could be used as an adjunct for diuretic therapy in patients with cardiorenal syndrome. The rising serum creatinine with ultrafiltration doesn't necessarily indicate an adverse outcome. Or E, ultrafiltration doesn't usually induce neurohormonal activation compared to diuretic use. So going rapidly over these, extracorporeal UF fluid is osmolar by definition, being a plasma ultrafiltrate. C is definitely right and is linked to what we previously discussed. D is also correct, since we can almost be, let's say, expected to have an increase in creatinine, also just modifying the volume of distribution of creatinine itself. And so we're left with A and E, but I'd say A, since these patients are usually sodium avid, and being UF fluid is osmolar with plasma, ultrafiltrate usually has more sodium concentration than the equivalent volume of urine. So A would be my answer.
Very nice. I think that's a correct answer, because actually, when we remove fluids with the extracorporeal ultrafiltration, we remove also sodium, because the ultrafiltrate is isoosmolar, but of course the urine has much less amount of sodium compared to the UF. And again, this is one of the advantage, because when you have more sodium in the body, it will collect and retain more fluid. So when you remove more sodium by ultrafiltration, you would expect also removal of more fluids. And of course, when you do this, if you are removing the same amount of fluid by using diuretics, you would anticipate that this patient may develop hypernatremia, kind of electrolyte imbalance, because you remove more fluids than sodium. And again, this is not helpful, because sodium retention is always bad for the heart, and also it will induce rebound increase of fluid overload after you de-escalate the use of diuretics. Of course, diuretics lead to more neurohormonal activation. So that's another drawback from using the diuretics. The other thing is, when we do rapid fluid removal by extracorporeal UF, you decrease the renal tamponade, you decrease the renal compression by edema. So it's actually could be helpful to avoid the diuretic resistance, because initial diuretic resistance could happen because of the increased interglomerular tension by the edema, the interstitial edema, and the tamponading effect of this fluid retention. Of course, as we just said, there is differences between removing fluid by ultrafiltration compared to removing fluids by using aggressive diuretics. Of course, the hospital stay, you would anticipate that it will be less inpatient when we use the extracorporeal UF. The amount of diuresis will be higher, the venous congestion will be less with the UF, and there will be a rapid and adjustable decongestion, less neurohormonal activation with the extracorporeal UF. Some studies showed improvement of the quality of life. Of course, you decrease the polypharmacy, so you're not using a lot of diuretics, and you remove more sodium with ultrafiltration, and also you could improve cardiac remodeling and ventricular function by using extracorporeal UF. Again, some references if you are interested to read more and to get more knowledge about how to treat your patients with cardiorenal syndrome. Okay, Rania, that's your turn.
Yes. Can I? Okay. So which statement is incorrect regarding the use of peritoneal dialysis in cardiorenal syndrome? Answer A, peritoneal dialysis is a continuous kidney replacement modality that does not require anticoagulation or central venous access. this is partly correct. Okay, option B, peritoneal dialysis is effective in removing sodium. C, peritoneal dialysis helps to preserve the residual kidney function and to improve left ventricular ejection fraction. Just a minute, the last one. Something is not, just a minute. Okay, the use of ecodextrine is associated with rapid fluid removal. Option E, peritoneal dialysis is a widely used modality in patients with acute cardiorenal syndrome. So I do not, actually, I do not have much experience with the peritoneal dialysis, but I do think we are going to choose the incorrect one. So peritoneal dialysis is a continuous kidney replacement therapy that does not require, this is correct, as I think. Peritoneal dialysis is effective in removing sodium. Let us see, peritoneal dialysis helps to preserve residual kidney function and improve LV ejection fraction. I know this is also, I don't, it's quite, peritoneal dialysis is a widely used modality. I don't think that this is the incorrect. I think the incorrect one is the last one.
Very nice.
Yeah, this
You
is
are right.
exclusion.
No, that's sad news, because we should actually encourage and try to implement more BD, which is a little bit safer way to control the volume and the uremia in patients both with acute and chronic cardiorenal syndrome. So again, BD is a continuous way of renal replacement therapy, and it doesn't require anticoagulation or central venous access. It's also has been proved that you can remove more fluids, especially if you're using concentrated glucose or icodextrin. You can have better weight loss, shorter hospital stay, lower risk of electrolyte disturbance, more sodium removal, and better preservation of the residual kidney function. It's very important because we know almost for fact now that BD can preserve or help to preserve the residual kidney function. You remember, even in patients on dialysis for a year or two, they still can make urine, they still have, low, but very important and crucial residual kidney function, and we need to preserve this. Also, in patients with acute cardiorenal syndrome, it's very important because they still can recover part of their kidney function. Icodextrin is also a very good way. It's expensive, but it's a very good way to remove more fluids. It's not glucose-based solution, so actually it doesn't cause any problems with hyperglycemia. Also, it doesn't affect the permeability of the peritoneal membrane. If you see the statistics here from the ICU, patient with acute decompensated heart failure who needs dialysis, 60 to 80% of them will be on CRRT, 15 to 30 will be on intermittent hemodialysis. SLED and BERT constitute about 10 to 20%. Isolated UF, 10 to 30%, but the lowest is the use of peritoneal dialysis. So I think we need to encourage and to teach our team that this is a good way to control both the uremic status and the volume overload in our patient with cardiorenal syndrome, acute and chronic kidney disease as well. Here are some references if you want to read about the value of peritoneal dialysis in patients with cardiorenal syndrome. Ido, this is your turn.
Okay, so regarding extracorporeal ultrafiltration in cardiorenal syndrome patient, which statement is incorrect? So A, in AKI, a net ultrafiltration of 10 to 12 milliliters per kg per hour is considered safe. In chronic hemodialysis, UF rates of 6.8 to 10 mL per kg per hour are associated with a lower risk of mortality, and this, I am pretty sure it is true. Reducing dialysis temperature and increasing sodium help achieve UF, limiting hemodynamic instability, which is also true, especially in chronic hemodialysis patients. POCUS, VEXAS, hematocrit, and BMP are useful tools to guide UF, which seems reasonable, especially if used together. Aggressive UF can induce organ hypoperfusion and dysfunction, which is of course true. So we're left with A, which is also a higher target than in chronic hemodialysis patients. So it should be the incorrect statement for this scenario.
Very nice, very nice. That's the correct answer. So what would you be your target for fluid removal in the acute settings, Edo?
Well, it is a very difficult question since it depends for the patient. We have discussed previously that there is a sort of J-curve for safe ultrafiltration in AKI patients. So if I remember correctly, it was about 1 to 2 mL per kg per hour. So a lot less for continuous renal replacement therapy, of course.
Very correct, Edo. You're very smart. Thank you so much for this. So remember, in acute settings, we need to be more gentle. These patients are acutely sick, critically ill. They have mainly AKI, so we need also to preserve their kidney function. If we do aggressive fluid removal, the chances that they would recover their kidney function might be less. So a net UF of 1 to 1.75 ml per kg per hour is considered safe. So if the patient is 80 kilos or so, average 70 or 80 kilos patient, you can remove net fluid removal of about 100 ml per hour. So it will, sum up to about 2.4 liter a day, which should be enough. Maybe at the beginning, if the patient has severe volume overload and his hemodynamics is not bad, you can remove more. But maybe after 6 hours or so, just try to maintain this 1 to 1.75 ml per kg per hour to give the chance of the kidney to recover. In chronic settings, in patients on dialysis with end-stage kidney disease or advanced CKD, you can remove much more because they are probably more stable, and also the chances they are going to recover some of their kidney injury, or they are going to lose some of their residual kidney function will be less. So it could be at least 6-fold higher in your fluid removal. And instead of targeting 1 to 1.75, you can target about 7 to 10 ml per kg per hour. So of course, in HD and CRRT, we try to cool down the dialysate and also to decrease the sodium. Sometimes we do sequential UF, or also try to change the sodium settings to help to remove more fluids. UF could be reduced to avoid hypoperfusion state if the patient cannot tolerate the UF, of course. Here are some clinical and biomarkers that we use to guide our ultrafiltration. Of course, at the beginning, the patient might have some fluid retention, edema, crackles on chest exam. We have the in and out, so we can calculate how much the patient is volume overloaded, or how was the volume balance. Of course, more recently, we are using the book as the point of care ultrasound. You can get some information about the B lines, the EE ratio. If it is more than 15, that's usually associated with aggressive fluid overload. The VEXAS score, which is 1 to 3. So if it is 3, that's mean that this patient are significantly overloaded. If there is some pleural effusion or ascites, this would be also an indication for fluid overload. Of course, we are using also biomarker, especially the NT-proBNP, and you can also use the BNP. And we see the hemoglobin and the hematocrit, and also you can use other biomarker like the CA125. So after removing fluids, after improving in the clinical status, you see that these clinical findings would improve. The BOCUS the B lines will disappear, A lines will appear, the EA ratio will be less than 10, VEX score will be 0 or 1, and the fluid in the pleural fluid or in the peritoneal fluid will disappear. The NT-proBNP will go at least 30% down. Hematocrit can go up about 8%. Hemoglobin will go up about 1 gram. CA125 will go down to 35 or less. Of course, serum creatinine actually can go up, and we are calling it permissive hypercreatinemia. So the initial rise of serum creatinine in patients with acute decompensated heart failure is not usually a bad sign. It could be a good sign, and the long-term effect of this would be better, and this patient actually would have better outcome, especially with the renal recovery, and the hospital stay will be less, and the mortality will be less. Again, if you are interested, you can download these articles and read more about the cardiorenal syndrome. And I really thank you so much, Dr. Rania Omer and Dr. Eduardo Terzolo for trying to help us to answer this question today. And thank you so much. And we'll see you again in our webinars.
Good evening. In this following 30 minutes, we'll discuss the ultrafiltration in critically ill patients against diuretic use. Let us see who is the winner in this our everyday clinical practice. We'll discuss in brief decompensated heart failure and the kidney with the mechanisms of diuretic resistance, aquapheresis and other renal replacement therapy modalities, and finally, randomized controlled trial and real-world evidence. Patients with decompensated heart failure with decreased cardiac output are at a great risk of both renal dysfunction, organ congestion, increased inflammatory cytokines, endothelial activation, and decreased tissue perfusion, all of that predisposed for acute kidney injury. Subsequently, ultrafiltration is recommended to improve the overall prognosis for those patients. Different diuretics have been used in patients with critically ill, in particularly in ICU. 3 different types, the furosemide, the bumetanide, and torsemide. The bioavailability is more for torsemide, reaching from 80 to 100%, while in furosemides it's around 60%. The furosemide orally and IV duration of actions, it's around between 2 and 6 hours. Furosemide is metabolized by the hepatic. The butanamide durations of actions and half-life is shorter, while torsemide has higher half-life. So optimizing effectiveness and managing diuretic resistance including increasing the dose, the frequency, or combined diuretic therapy. Monitoring for adverse events like electrolyte imbalance is important. Patient with heart failure with volume overload status and diuretic resistant may get benefit from slow continuous ultrafiltration. Increasing in the neurohormonal activities and decreasing of the renal blood flow with increase in the venous congestion and renal venous pressure with worsening of renal function. Ultrafiltration may be applied to close this circuit. Use of loop diuretics in decompensating heart failure is also challenging, as intravenous diuretics may induce a rapid diuresis that reduces lung congestion and dyspnea as a positive effect. However, its effectiveness declines with repeated exposure, with unresponsiveness, with the unresolved congestion may contribute to high rehospitalization rates. And also, loop diuretics may be associated with deleterious effects on neurohormonal activations, beside electrolyte balance and cardiac and renal function impairment. Organ congestion, including poor wound healing, susceptibility to infection, cellulitis in edematous limbs, cerebral congestion with persistent encephalopathy, myocardial edema including diastolic dysfunction or conduction disturbance, atrial fibrillation, pulmonary congestion including prolonged ventilatory weaning, hepatic congestion including cholestasis, altered protein synthesis. In patients with acute kidney injury, kidney congestion may deteriorate the kidney function. Gut edema will induce malabsorption of drugs and nutrients, ileus, and importantly correlated to inflammation during congestion states of the gut due to translocation of the endotoxins and bacteria. The hemodynamic disturbances caused by excess or overly rapid fluid removal, on the other hand, will induce organ stunning, characterized by cognitive dysfunction, delirium, myocardial injury, and serious ventricular arrhythmia. Intestinal ischemia and kidney ischemia, rapid loss of residual kidney function, and risk of mesenteric non-obstructive intestinal ischemia. Again, toxins and bacterial translocation due to ischemic gut. With different mechanisms of diuretic resistance, it's beyond this talk. We will highlight just some points. It may be due to tubular tolerance, including enhanced reabsorption at the proximal convoluted tubules, which limit the delivery of the diuretic to the lobe of Henle. Or it may be an increased reabsorption at the distal convoluted tubules and the collecting duct, which counteract diuretic blockade of sodium reabsorption in the lobe of Henle. We may have also a pathophysiology like decrease of the cardiac output, renal congestion with increasing in the central venous pressure, patient with hypoalbuminemia with decreased plasma albumin. The overall with decreased renal blood flow and estimated GFR is predictor of lower response to diuretic. So the mechanism of diuretic resistance in 5 points. For the orally achieved drug dosing, we have a variable GIT absorption with a furosemide bioavailability between 10 to 100% influenced by food intake and gut edema. We have hypoalbuminemia with less delivery of diuretic to the kidney, plus free drug molecules that diffuse into the tissue. We have also decreased the kidney perfusion by the low mean arterial pressure, which limits the secretion of loop diuretics into proximal tubules of fluid, and the glomerular filtration of water and sodium. We have also competition for transport channels, like urea, which use the same transport channels and decrease diuretic entry into the tubular lumen. And finally, with reduced kidney function and decreased functional nephrons, the mass means less sites for loop diuretics to act on. Although aquapheresis is an effective alternative therapy for an ultrafiltration, however, many aspects of aquapheresis, including correct patient selection, targeting fluid removal rates, the venous access required, the prevention of therapy-related complications, and definitely the cost. It should be noted that patients in ICU may develop acute kidney injury or even multiple organ failure. So the applications of the extracorporeal treatment may not include only ultrafiltration and may extend to prolonged intermittent renal replacement therapy or hemodiafiltration or even continuous renal replacement therapy according to individualized patient requirements. Different modalities in ICU, including convection therapies to remove cytokines by using dialyzers with high permeability or high volume convection therapy like hemodiafiltration and hemofiltration. It may include adsorption therapy to specify an adsorbing material like polymyxin for lipopolysaccharides adsorption or heme adsorption like cytosorb, or combined therapies with combined filtration and adsorption techniques like Aquapheresis in CRRT therapy. Sometimes coupled plasma filtration adsorption technique, and finally some indications specifically for plasma exchange. Prescription of the mechanical fluid removal. As suggested by the Acute Disease Quality Initiative Expert Group, the main indications for mechanical fluid removal in heart failure is as following. Patients with fluid overload after diuretic failure, presence of serious adverse effects of diuretics with little response where treatment with diuretics cannot be continued. With high chance of diuretic failure, example in case of significantly reduced renal function, where diuretics are unlikely to be effective, with the risk of a prolonged and progressive fluid overload state is high. And finally, combined fluid overload and advanced renal failure. It's the situations where both fluid removal and solid clearances are required. Ultrafiltration is a broad term describing removal of hypotonic or isotonic fluid from the intravascular spaces, which is using a pressure or concentration gradients across a semi-permeable membrane. In case of dialysis, there is a concentration gradient, while isolated ultrafiltration using the pressure gradient. Its efficacy is not dependent on the drug sensitivity or the delivery. It can be calculated and titrated more precisely than medical therapy. And finally, it's slow and prolonging the process allows for plasma refilling to maintain an intravascular volume. Such maintaining the intravascular volume can prevent activation of the RAS system. Patients with acute kidney injury associated with decompensated heart failure will need more renal replacement therapy in the form of dialysis. We can do dialysis in a slow techniques like prolonged intermittent renal replacement therapy or CRRT. It should be noted that in such a scenario, those patients will need a vascular access with a central venous catheter. Choosing the right dialyzer to remove the cytokines and the small solid toxins is needed. With a dialysate prescription, in a low flow dialysate around 200 to 300 ml per minute, that ensure removal of retention toxins, both for small solids and the middle molecules if we are using a high permeable dialysis membrane. In this table, different modalities for treatment with acute kidney injury using intermittent hemodialysis, prolonged intermittent renal replacement therapy, and the standard CRRT. In ICU, we are using both the PERT and the CRRT, which using diffusion and convection if you are using high permeable dialysis membrane in PERT. Augmented convection as per the therapy with continuous veno-venous hemodiafiltration. However, ultrafiltration alone with minimal convection, removal of middle molecules and excess fluids, but no diffusion here. The blood flow usually are between 100 and 300 and slower in CRRT. It's a continuous, but here we are using about 12 hours per day and for 4 to 7 days. The dialysate flow are typically slower. In case of dialyzer surface area, we can use bigger dialyzer up to 1.5 square meter. All need anticoagulation, but for CRRT need more anticoagulation. The dialysate and potassium are prescribed according to the patient need, and the dialysate calcium is typically 1.5 millimole per liter. However, it's 0 if we are using regional citrate anticoagulation. For the CRRT patients, additional phosphate may be required to the standard CRRT fluids to switch to commercially available phosphate-containing fluids if not available. So renal replacement therapy or volume management by extracorporeal treatment depending on the patient's situations. We may need a fast intermittent hemodialysis in critically patients with hyperkalemia, for example, or for toxicology reasons, like polyethylene glycol. You need a fast removal, so we have to use a faster process like intermittent hemodialysis, provided hemodynamically is stable. And it's the best choice for patients with life-threatening hyperkalemia. Or may use prolonged intermittent renal replacement therapy when the patient in ICU needing more slower treatment. And finally, the continuous renal replacement therapy when hemodynamically unstable patient requiring 24-hour therapy. It's all about the time required during treatment. We may have short, more prolonged, or more continuous. The process itself, depending on the mechanism of removal, we may have diffusion to remove small solids. We may combine with convection, usually with continuous veno-venous hemodiafiltration or hemodiafiltration, and the ultrafiltration required to achieve the dry weight of the patients on a slow techniques. So patient selection for an extracorporeal blood purification or ultrafiltration depending on multifactors. Which toxin you need to remove, which type of extracorporeal therapy, and which type of dialysis machines. There is a U-shaped risk for patients on dialysis, including the hypovolemia and hypervolemia status. So clinical precision of the fluid status is important for patient safety on dialysis. While hypovolemia induces intradialytic hypotension and altered tissue perfusion, including confusion, risk of cardiovascular accident, splanking, ischemia, and multiple organ failure, while hypervolemia, including edema, increase in the intra-abdominal pressure, respiratory failure, impaired healing, altered mobilization, and organ failure from congestion. Volume overload status in ICU patients is always a problematic, either to give a high dose of diuretics, loop type, or to move to aquapheresis, meaning ultrafiltration without dialysis. Aquapheresis using a dedicated machine with a very tiny filter for convection removal of excess fluids without dialysis, or can be used with CRRT machine using the SCAF mode. In the clinical trials that will be shown on the following slides, the reduction in rehospitalization from heart failure and the improvement later on diuretic response, with some of positive and negative results on the clinical trial. However, the majority of trials showed improvement in rehospitalization, but non-significant improvement against loop diuretics in mortality. On this video, we will have some of the information of the technique of aquapheresis using such a tiny 0.2 square meter surface area dialyzer. Such filters are applied to a dedicated machine with a blood pump, pressure monitoring, air trapping, and a detector. It needs a vascular access as any of the extracorporeal circle, with a movable device inside the ICU, and precisely can control the volume of ultrafiltration per each session. Such a device may be of support for patients with only hypervolemic state, not on uremic state. The removal of excess water is by convection, as no dialysate, so diffusion and removal of the small solids, toxins, will not be possible by this way. It should be noticed that in aquapheresis there is no dialysate, subsequently there is no diffusion, and this machine is only applied for a slow ultrafiltration techniques, removing the necessary volume of ultrafiltration with multiple control panels, utilizing the peripheral or the central venous axis. Patients with aquapheresis needing a precise control of the hypervolemic status, judgment by both the clinical central venous pressure measurements, other measurements like ultrasound on both lungs, and bioimpedance techniques, as in hemodialysis also hematocrit measurements that increase by ultrafiltration can judge the volume status of the patient and the amount of volume needed to be removed. So this is a device that measures the hematocrit and precisely define how much of fluids is suitable to maintain a target hematocrit. It should be noted that ultrafiltration may have a transient intravascular depression that may result in initial diversions from the expected clinical normalization of diuretic therapy. Clinicians should note that a flexible ultrafiltration rate guided by the clinical and biochemical picture is likely to avoid adverse renal outcomes, while it appears to be most beneficial when given earlier before renal deteriorations. In all cases, that ultrafiltration is not better at improving cardiac biomarkers when used alone. And finally, ultrafiltration may maintain decongestive superiority over diuretics and in a shorter period of time. Additional tools like VEXIS is required in the ICU to determine the fluid volume status, and typically it's in the 4 steps. Step 1, to measure the inferior vena cava diameter and its collapse. If it's more than 2 centimeters, go to step 2 to measure the hepatic venous Doppler, either normal or severely abnormal. And third step, to measure the portal vein Doppler. In the same way, normal, mild, or severely abnormal. And in step 4, to measure the renal vein Doppler and to determine the state of the fluid. Interpretation and measurements need a dedicated expert team who can grade from 0 to grade 1, grade 2, and grade 3. A multidisciplinary team is advised in the ICU for the better outcome of the volume control of patients with or without acute kidney injury. Several trials have been done for more than 20 years is to examining the ultrafiltration for the heart failure. We'll have a short note on that, like the unload, the CARES heart failure, and avoid heart failure trials, and finally, the meta-analysis. Is a multi-center prospective randomized controlled trial containing 200 patients involved in this trial. The results summary demonstrated significantly greater weight and fluid loss than diuretics, favoring ultrafiltration, with 53% reduction in the risk of readmission with ultrafiltration group. The CARES, in the same way, it's a multi-center and prospective randomized controlled trial having 188, but it showed no difference in weight loss, with no significant difference in death or rehospitalization. In the same way, ultrafiltration group had a higher serum creatinine. And the avoid heart failure. It's a multi-center prospective randomized controlled trial giving the larger number in these 3 trials, 224. It shows also significantly fewer 30-day rehospitalization with significantly fewer days in the hospital due to heart failure readmission and lower rehospitalization rates due to cardiovascular event. So in brief, the UNLOAD trial concluded that in decompensated heart failure, ultrafiltration safely produces greater weight and fluid loss than intravenous diuretics, with reducing 90-day resource utilization for heart failure, and is an effective alternative therapy. During the first 48 hours after enrollment, hypervolemia was treated exclusively with ultrafiltration and stopped all diuretics. The duration and rate up to 500 ml per hour. It seems higher rates are used in this study. It depending on the treating physicians and the patient condition. The ultrafiltration arm showed better weight loss comparing to the loop diuretic group. With an ultrafiltration group had higher serum creatinine changes before discharge and after discharge. However, after 30 days and more are more stable than with diuretic use. Percentage of patients free from rehospitalization favoring the ultrafiltration alarm with 16 events and in the standard care 28 events. This also favoring the ultrafiltration arm. In 2012, A clinical study randomly assigned to a total of 180 patients with acute decompensated heart failure, examining the worsening of renal function and persistent congestion to a strategy of stepped pharmacological therapy, and the other group of ultrafiltration applied. Creatinine increase in the ultrafiltration group comparing to the pharmacological therapy and significantly at 96 hours in the ultrafiltration group. However, the increased serum creatinine was minimally in the range of 0.23 milligram per deciliter. Both of them, ultrafiltration and the pharmacological therapy, achieved the dry weight and volume loss effectively. The decrease in the body weight in both groups achieved at different times up to 60 days was comparable and between 9 to 10% with ultrafiltration and pharmacological therapy. The risk of complications, including serious adverse events, was mainly electrolyte disorders in pharmacological therapy, and extracorporeal therapy showed more gastrointestinal hemorrhage, anemia or thrombocytopenia, and other complications including sepsis or cellulitis. Both of them achieved the goal of ultrafiltration and maintained ultrafiltration at 60 days. The third trial, called the Avoid Heart Failure Trial, patients enrolled 110 for ultrafiltration and 114 to intravenous tube diuretic therapy. Patients hospitalized for heart failure were treated with adjustable ultrafiltration and adjusted loop diuretics. In this Avoid Heart Failure trial, comparing both groups trended toward a longer time to first heart failure event within 90 days and fewer heart failure and cardiovascular event. However, due to the trial's ultimately terminations, additional investigation is warranted. Compared with the patient with loop diuretic group, ultrafiltration group trended toward a longer time for their first heart failure events within 90 days and fewer heart failure and cardiovascular events. In addition, the secondary endpoints showed an efficacy toward the ultrafiltration group and greater total amount of fluid removal and net fluid loss. However, there was no statistically significant difference between ultrafiltration and augmented loop diuretic groups in terms of weight loss at 72 hours. A systemic review of the Aquapheresis in patients with heart failure, and using the terms Aquapheresis as a slow process of ultrafiltration, can use slow continuous ultrafiltration or as an ultrafiltration interchangeably. Ultrafiltration and aquapheresis had more significant reductions in weight and may even decrease the rehospitalization at 90 days. However, since ultrafiltration does not improve survival in patients with heart failure, limiting factors to its use guide the cost, the need of multidisciplinary team, vascular access, catheter-related adverse events, and renal side effects with increasing the serum creatinine, either from hemoconcentration effect or from volume-dependent renal blood flow. Available trials have enrolled patients with HFrEF and HFpEF, and patients with mild to moderate kidney dysfunction resistant to diuretic therapy but stable blood pressure. The summary of the systemic review of the literature showing that ultrafiltration is an effective method to remove excess fluid in patients with acute decompensated heart failure. However, it cannot only be used as an alternative in patients who develop resistance to intravenous diuretic, but may also potentially as a first-line therapy within 24 hours of admission. This question marks on initiation of ultrafiltration. For my opinion, I prefer to start first an augmented loop diuretics first before jumping to ultrafiltration. With several trials have shown that it produced more significant reduction in weight and many even decreased the rehospitalization rate within 98 days. Since ultrafiltration does not improve survival in patients with heart failure, limiting factors to its use include cost, the need of a multidisciplinary team, catheter-related adverse events, and renal side effects. It may also prolong acute kidney injury status if ultrafiltration was applied with intradialytic hypotension episodes. In this 10 years real-world study showing that the mean fluid removal was 14 liters per person removed by ultrafiltration treatment. The overall mean increase in blood urea nitrogen with ultrafiltration was minimal. On follow-up of blood urea nitrogen on admission and pre-ultrafiltration and post-ultrafiltration, pre-discharge and discharge or follow-up of patients revealed that there is improvement in the fluid volume status still, no much increase in the blood urea nitrogen subsequently. The same finding for blood urea nitrogen is also applicable for serum creatinine, and the estimated GFR changes upon stopping ultrafiltration at discharge and on follow-up was considerably low, with less than 2 milli per minute per square meter surface area. So the loss of 1.5 after ultrafiltration treatment is safe, and these 10 years real-world experiences confirm that ultrafiltration to be safe with regard to renal function, despite the cohort in this study being patients are more sicker than those studied in the other clinical trials. So in conclusion, who is the winner? Considering fluid overload is a risk factor for increased morbidity and mortality, especially in patients with decompensated heart failure. The treatment options are limited to diuretics and mechanical fluid removal using ultrafiltration or renal replacement therapy. The role of extracorporeal fluid removal has been investigated in several landmark trials, comparing ultrafiltration versus diuretic-based regimen, with mixed results in patients with acute heart failure or cardiorenal syndrome. So the decision between ultrafiltration alone versus renal replacement therapy or aquapheresis, depending on the clinical needs of the individual patients, and putting in mind that when using extracorporeal fluid removal, implementation of a customized and individualized ultrafiltration rate is essential in order to avoid the harm from the intravascular hypovolemia and hemodynamic instability that induce many organ stunning. Thank you all for being with us.
Thank you so much, Professor Hesham, Dr. Manu, and the
Panelists, please feel free to address the questions and answer any concerns.
I think for Dr. Hesham Elsayed, I see in the question and answer box that delegates are asking whether there is any difference with respect to fluid removal or toxin removal between hemofiltration scuff and the aquapheresis. Could you just briefly explain this, the differences?
Yeah, thank you very much, Professor Manu. Yes, therefore, it's extremely different between both of them. If you are in need to remove small solid, you have to apply for dialysis with a dialysate. This is one scenario. The other scenario is about the slow continuous ultrafiltration and huge volume convection therapy like hemofiltration. It's a matter of calculations. Due to this very slow technique and the slow volume of the scuff or the aquapheresis, it is insignificant removal of the middle molecules, including cytokines. So in inflammatory status or septicemia, you need more convection therapy that's equal or more about 6 liters, for example, per hour in high convection therapy during hemodiafiltration, or slower in cases of continuous renal replacement therapy. So scuff or aquapheresis is not designed to remove toxins, while other higher convection therapy or combined diffusion convection therapy is the actual renal replacement therapy to remove toxins, including cytokines.
Thank you. And there's a question with regard to the pediatric population. Should we aim for hemodiafiltration over conventional hemodialysis, or what would be the best technique there?
Yes, in pediatric and in adults, we prefer to doing more convection therapy, considering the latest trial of Convince and other trials during the last decade of improving of the survival by higher convection therapy above 23 liters per square meter surface area, per adult square meter surface area. In our experience here, almost all pediatric population are doing hemodiafiltration, either bridging for transplantation or for maintaining on hemodialysis. So I agree completely that preferred to do 100% of our patients in pediatric group on hemodiafiltration treatment.
So I have a question from my side. I come from the critical care and we use CRRT. So these techniques, what kind of anticoagulation do they need? And are they prone to clotting? Do we have these problems? Do we know about these problems in patients in critical care units, which can have quite altered coagulation profiles and different problems in this area?
Yes, sir. It's multifactorial, considering the coagulation per patient's requirement and by the technique requirements as well. For the patient scenarios, hypercoagulable state, we faced a lot during COVID. You can remove the circuit every 6 to 8 hours due to hypercoagulable states. One of the limiting steps of coagulations inside the CRRT is to maintain both a convection volume that is stable without increase of filtration fraction above 20%, number one, and number two is to maintain a good blood flow around 200 milli per minute of the blood flow during CRRT. So there is a technical and patient-specific criteria for clotting of the extracorporeal therapy. Coming to your second question that has no definite answer, on the literature, the citrate anticoagulation seems to be more favorable for the anticoagulation effect. However, it's difficulty during the anticoagulation procedures and the risk of calcium imbalance, metabolic alkalosis, and others. So if you have expert in the citrate anticoagulation, you can proceed safely, and it's the best way. provided you have a calcium-free dialysate, and everything is monitoring, including ionized calcium to total calcium ratio. If you don't have such experiences in citrate, so you can go with either unfractionated heparin or low molecular weight heparin. You can judge by PTT, for example, if you are using the high molecular weight heparin. Unfortunately, anti-factor X is not routinely done. So in all cases, I prefer citrate if you are expert. If you are not expert in that, you have to move to both either unfractionated or low molecular weight heparin, with both of them have the same risk factor to develop HIT during DIC, or that it will be problematic to decide the thrombocytopenia is coming from which type, septicemia or from heparin. So I think each center shall develop their strategy for anticoagulation.
Thank you so much, Dr. Hesham. I think we have an advantage of having Dr. Ashraf Al-Tayyar with us. He's a BOCUS expert. And just in a minute or two, Dr. Ashraf, just guide us how to better and precisely assess the volume control of our patients using the BOCUS.
Yeah, thank you very much, Dr. Amr, and thank you for the panelists. I enjoyed really the session. In very short time, assessing the volume status in ICU in general, and particularly with renal replacement therapy for those who are having renal failure, very tricky and commonly asked question every day. The issue is that commonly we have patients in ICU with failure and left ventricular failure. And both of ventricles, when they are failed, they are most likely preload dependent. And when you remove fluid from those type of patients, which is a common indication to use CRRT in ICU, you have to be very cautious that you have to have evidence that the cardiac output would not be reduced when you remove fluid. Because if you rely on VIXAS, as Dr. Hesham mentioned, if we rely on VIXAS in critically ill patients, it's sometimes misleading. VIXAS have to do IVC, portal vein, hepatic vein, as well as with intrarenal veins. Majority of these are difficult in critically ill patients. And most of our critically ill patients are having high intra-abdominal pressures. So you might have false results of VIXAS. And if you decide to remove fluid based on VIXAS, and then you don't mind or you don't care of the left ventricle and right ventricle cardiac output, then you remove fluid, then you jeopardize the hemodynamics. And it's a vicious circle because the kidney will be jeopardized at the end of the day. To cut it very short, you have to put in mind that point of care ultrasound is very beneficial, but look at the picture as a whole. You have organs who are congested, but you have to be sure that the intravascular volume is not depleted, because it's commonly seen that the intravascular volume might be depleted and you remove more fluid, or continuously blindly you're removing 100 ml or 200 ml per hour, but then you don't care about what is going on intravascularly, assuming that intravascularly patients are hypervolemic. This is not the case in 100% of patients. Not only that, but also left ventricle and right ventricle. Right ventricle is commonly forgotten in critically ill patients. And sepsis is commonly involving RV, by the way, more than even the left ventricle. And if you remove fluid for a failing left ventricle, which relies on the preload, you jeopardize the cardiac output of the RV and eventually the left ventricle cardiac output. So again, intravascular, of course, this needs maybe a lecture or two, but to cut it very short, puzzles has to be put all together, and you gain, especially those who are still our young fellows, you have to put in mind that patient is a puzzle, group of puzzles. One of them is the congestion score by ultrasound. Should not forget the left ventricle, right ventricle, and the organs, especially the lung. How is the lung? Is it congested or not? And easy, you can know this by ultrasound. Hopefully, with our program of point of care ultrasound fellowship program, which we're gonna launch it maybe within the next few months, you'll be able to learn more about use of point of care ultrasound in critically ill patients. And big issue or big subject here is with renal replacement therapy. Thank you very much.
Thank you so much, Dr. Ashraf. Dr. Ricardo, Dr. Craig, feel free to add, Dr. Khaled.
Can I put a question? First of all, I have to say, Professor Hesham, that I like very much your talk. It was amazing. I came from intensive care, and usually the patients I have are septical patients, hemodynamic unstable patients. The question I would like to put to you is, what do you think about these hybrid techniques in order to become a bridge between CRRT and intermittent hemodialysis? Is really used to do that? Practical terms, is good to do that? Is advisable to do that? Or that is a mistake? What is your opinion? And other point is, concerning SLED, do you think the cost effectiveness of SLED is really less expensive than CRRT?
Thank you, Dr. Ricardo. Very nice question, and thanks again to highlighting that. And I will come here with both the guidelines and my personal issue. According to the guidelines, which is 13 years ago, for the clinical guidelines saying that CRRT should be delivered for patients in two case scenarios, importantly, patients with increase of intracerebral pressure or brain edema, and the second strict is the hemodynamic completely unstable. Upon that, after 12 years, there was no PERT. PERT subsequently developed later, and PERT on the meta-analysis and all the clinical trials showing that with the same results for the CRRT. Important point is not this or that. It's filling on each other. For example, you can start your patient with CRRT because for hemodynamic unstable with low mean arterial pressure or with acute brain edema. And when possible improvement, you can go to the hybrid of the PERT or the reverse. Some of the guidelines of the away from the clinical guidelines implementing PERT, like Canadian guidelines, as a first line of treatment. To my opinion and personal opinion in that, for this long time, we have both modalities in the ICU. Whenever possible, I try first PERT. It's an easier, cost less, and more friendly and effective even in removal of small solid rapidly, as Professor Amr said excellently. If you have a patient with severe hypervolemia or hyperkalemia stating life-threatening process. Or you can have on the same way, in the same ICU, a CRRT that deserve it for more critically ill patients as per the guidelines. For your questions, yes, we have to implement both. You have to choose between both and deserve the CRRT for more lower incidence of patients that require actually CRRT. For your second question, just repeat because the voice was not clear.
Effectiveness of the SLED technique is yes. The cost of effectiveness, if sustained low efficiency dialysis is less cost, and if it's cost effective compared to CRRT.
Yes, SLED is exactly the new name is the PERT. So SLED is just a slow, low efficiency dialysis. Low efficiency means momentary clearance of solids. But on the period of time, 12 hours, it's not low efficient, it's a high efficient dialysis. So low efficient dialysis had been substituted by the PERT, and the PERT now we have a PERT F, which is filtration. So we can add filtration technique during PERT like slow hemodiafiltration or sustain the hemodiafiltration technique. But no one in the modern are calling for SLIT for 3 or 4 years ago. But in particularly, you can use PERT as 12 hours during CRRT machines, but it's cost. So final results is that PERT, it seems that PERT is the main player in the ICU, and second player should be CRRT in some selected cases, not all cases in the ICU.
Thank you very much.
Thank you.
So I have an input from my side. I also wish to thank for this great talk. In the critical care, we think like this. When the patient is in shock, very unstable, we need to use CRRT. And when the patient improves, we switch over to intermittent technique. And the benefit is not always from the dialysis side. The benefit is that with the intermittent technique, we are able to mobilize the patient more because dialysis is done only a few hours over the day and night, and the rest of the time the patient is free from this treatment and can be mobilized. And this is of very big importance for the patient's recovery. There was a secondary analysis published in critical care recently where it was shown that when the SOFA score is low, the patient is very unstable, CRRT has an advantage over intermittent technique clearly. And when the SOFA score goes up and the patient becomes more stable, this advantage vanishes, and then the intermittent technique is as good as CRRT. And I think that this aspect of possibility to mobilize the patient is very important. So what about these techniques? They are going on for a very long time and they will trap the patients to the bed, basically. What would be your answer on this issue?
Yes, I fully agree. Definitely, mobility is better for prolonged intermittent renal replacement therapy. I just highlight here, intermittent may be conventional 4 hours. That's away from our decision usually because it's a very rapid shift in osmolality, and changing rapid of osmolality and the brain can induce many of the brain edema, or sudden change of osmolarity or electrolyte or acid base can impair, especially for the CO2 transmission from the dialysate side that can induce hypercapnia. So if your respiratory system is not intact or the brain is not intact, the patient can develop hypercapnia. So the least choice is the conventional 4 hours hemodialysis, and we don't go for that usually in critical care patient. But we always balance it between the prolonged intermittent renal replacement therapy and CRRT. And for sure, you perfectly said that PERT is more preferable mobility, giving a chance for everyday practice, laboratory, radiology, and other interventions, even in drug control, because CRRT drug control is very risky to control all of the antibiotics and the other pharmacology, while PERT is more smooth and easily controlled, and it gives the same results for toxin removal if you apply with a high permeable dialysis membranes.
Thank you so much, Professor Hesham. Very intellectual, very thoughtful educational session tonight or today, wherever you are. I really appreciate the contribution of this multidisciplinary team between nephrology and critical care physician. Thank you everyone for your contribution. And hopefully within the next month or two, we'll continue this series of volume control and acid-base disorder management in combination with acute and chronic settings between the CRRT intermittent dialysis, between our 2 World Kidney Academy fellowship, the Critical Care Nephrology Fellowship, and the Renal Replacement Therapy Fellowship. Once again, thank you, and we'll see you again in the near future.
Thank you very much.
Thank you very much.
Thank you.
Thanks.